Welcome to this module on diabetes. There are specific pit stops for tasks as it proceeds that you may wish to pause the recording for before continuing. It is designed to either be listened as a vodcast or as a podcast. The module is split into two sections, with the second module covering how to diagnose diabetes and the role of the glucose tolerance test. I hope you enjoy the module. The learning outcomes of the module are to be able to discuss the importance of diagnosing diabetes correctly, to understand how often diabetes is misdiagnosed, to describe which patients should be screened for diabetes, and to describe the tests used to screen for diabetes. Diabetes itself is a common condition with 3.1 million people with diabetes in the UK. Of these, 800,000 remain still undiagnosed. By 2020, it is estimated that nearly 1 in 10 of the adult population will have diabetes. Accurate diagnosis is vital to ensure that they receive the correct treatment to reduce the complications from the condition, as different types of diabetes are treated in different ways. Therefore, it is important to both get the diagnosis as well as the type of diagnosed diabetes correct at the start. You would have thought that testing for diabetes should be easy. You get a patient, take a blood test, and that's that. Unfortunately, this is not the case. Pit stop 1, misdiagnosis. What percentage of patients with diabetes actually have diabetes? A recent study commissioned by the RCGP and Diabetes UK looked at the number of patients on a general practice diabetic register who were either misdiagnosed, didn't actually have diabetes. This amounted to 2.2% of the patients on the register. Misclassified, these were people who had been given the wrong type of diabetes but were still diabetic, and this amounted to 2.1% of the patients on the register. And finally, those who were miscoded, where they couldn't determine from the computer which type of diabetes they had. And this was 1% of the register. If we purely look at those that were misdiagnosed, i.e. didn't actually have diabetes, this amounted to 1 in 50 patients on a diabetic register. It is vitally important, therefore, to get the diagnosis correct at the start. We'll now turn to screening for diabetes. You're now at pit stop 2, who to screen. Which patients would you routinely call in to screen for diabetes? General population screening is not suggested, but certain patients in high-risk groups can be identified, and these include the white population of greater than 40s, or people with black, Asian or minority groups greater than 25 with one or more of the following risk factors: a first-degree relative with a history of diabetes, body mass index greater than 30 kilograms per metre squared, a waist circumference greater than 94 centimetres in men and 80 centimetres in women. Other groups should also be screened. These include people with a history of ischemic heart disease, cerebrovascular disease, peripheral vascular disease and hypertension, people with a cardiovascular risk score of greater than 20% over the next 10 years, and people on certain medications such as atypical antipsychotics. At pit stop 3, we'll now look at the screening tests that are used. What screening tests do you know for diabetes? The following are all thought to be used to diagnose diabetes, but not all are: fasting plasma glucose, random plasma glucose, HbA1c, so-called glycosylated hemoglobin, urine dipstick, and the glucose tolerance test. Of these, there are only 3 currently accepted ways to diagnose diabetes, and they are the fasting plasma glucose, the random plasma glucose, and a glucose tolerance test. Urine is not used as a way of testing since there are different renal thresholds for glucose, leading to glycosuria between individuals. HbA1c has been controversially suggested as a way of screening for diabetes. The level being proposed is that of 6.5% and above. There are certain advantages of using the HbA1c as a screening tool, and these are: the patient does not have to fast, single measurements are more accurate on repeat testing, unlike the glucose tolerance test that we'll look in the next module. All UK laboratories are now standardised for HbA1c measurement. It saves having to measure several glucose levels over several weeks. And finally, it may well be a more cost-effective option when the whole screening pathway is included. There are, however, certain disadvantages of using HbA1c. If the patient is anemic, is in renal failure, or has certain hemoglobinopathies, it may well be inaccurate. Levels may vary between different age groups and different ethnicity groups. And finally, it's only a surrogate measure of the glucose level and not the actual measure. Currently, it is only recommended for measuring in the control of diabetes and not the diagnosis. However, this may change in the future. This is the end of the first module. The second module will cover how to diagnose diabetes and the glucose tolerance test.